Hi everyone, welcome again to LUCC, Learning Ultrasound in Critical Care. This module is going to talk about, I'm going to talk about abdominal ultrasound. And remember once again that we are talking of point of care ultrasound done at the bedside by a non-radiologist, which means that we'll be mainly talking about clinically relevant focused ultrasound. My name is Arvind Rajamani and I work in Sydney at the Nepean Hospital. Now, before we go to the actual talk, let's just have a refresher on the anatomy. Okay, we all know this stuff by heart. Now, in the right upper quadrant, you have the liver. Okay, and that's a huge structure, and you are never going to miss the liver. If you keep the ultrasound probe anywhere along the right upper quadrant, you should have some part of the liver. Okay, just inferior to liver, you have the kidney. And getting the kidney is a little bit tricky. The best way to do that is just to follow the course of the liver and go down. Okay. On the left side, you have the spleen and the kidney in a very similar relationship, except that the spleen being smaller, it is a little bit more posterior and more difficult to find. And also, because the spleen is smaller, the left kidney is more cephalad compared to the right. So they are not at the same level. They're at a the left kidney is at a higher, more superior level than the right. Then you have the gallbladder, roughly about a few centimeters paramedian, so to the right of the midline. And in the midline, as a horizontal structure, you have the pancreas, and the bowels are just all over. Okay, the bowels occupy every space that they possibly can, which is not occupied by the solid organs. So wherever the solid organs are not there, the bowels just occupy that space. And sometimes when you have ileus and you have bowel distension, that's obviously going to make it very difficult to see all the solid organs, because the bowels are filled with gas, and as we know, gas is not the friend of ultrasound. Okay, when you have a lot of bowel gas, you really can't see much, and that's specifically true for the pancreas, which is a retroperitoneal midline organ, which means that if you have the stomach and the transverse colon full of gas, it's going to be very, very difficult for you to image the pancreas, which is just posterior to them. Then you have the vessels, okay, the big blood vessels. That's the abdominal aorta on the left of the midline and the IVC, or the inferior vena cava, on the right of the midline. Then you also have the portal system, and that starts from the splenic vein behind the pancreas and the superior mesenteric vein, and the two of them behind the head of the pancreas, they join to form the portal vein, and the portal vein goes to the liver, and it forms the left and the right, the left and the right branches of the portal vein. Okay, and then you have the biliary system, which is formed by the common bile duct, and the pancreatic duct, and they both open in the third part of the duodenum here. The intrahepatic bile ducts are they're the ones that join to form the common bile ducts. Now, some of the other structures in the lower midline include the urinary bladder, uterus in females, the rectum in the midline, the lower midline, and there's a pouch in between the urinary bladder and either the uterus or the rectum. So it's called the rectovesical pouch in males, and it's called the rectouterine pouch in females. So now let's go to the focused ultrasound of the gallbladder as part of the LUCC examination. Again, a brief review of the gallbladder anatomy. The gallbladder is a structure that's present in the right hypochondrium just under the liver. The neck of the gallbladder is the location where it's actually attached to the liver, okay, to the portal triad. That is fixed, so that is a fixed neck. But the body of the gallbladder, which is here, is a rather mobile structure. It can just go anywhere along the right costal margin. So it can be, depending on the gravity, depending on whether it's full or empty, it can be anywhere from here to here. So you'll have to search. And it's obviously, the body is bigger than the neck, and therefore it's easier to identify on ultrasound. So you start off with a wide sweep along this area under the costal margin to look for the body of the gallbladder. Okay. The size of the gallbladder depends on the prandial state. So it depends on whether you're fasting or whether you've eaten. And therefore it's variable. and therefore there's no real value to looking at the size of the gallbladder. So there's no point saying the gallbladder is large or gallbladder is small. But one condition: it's unusual to have a gallbladder that's more than 10 centimeters long and more than 4 centimeters in the transverse. So if it's a huge gallbladder like this, then perhaps in the appropriate clinical setting, you may think of acalculous cholecystitis. Sorry, you may think of cholecystitis or a distended gallbladder. Okay, right. Now, so that's the gallbladder there, they're tracing beautifully. Now, as I said, the neck of the gallbladder has some fixed anatomical relationships. And the neck of the gallbladder is related to the main lobar fissure. So the fissure that divides the left and the right lobes, the left and the right lobes of the liver, is called the main lobar fissure. And the gallbladder neck is related very closely to that. And this results in what is called an exclamation mark sign, which I'll show you. Okay. Now, at the same location here, you have the common bile duct, and you also have the portal vein, and you will see, and you also have the hepatic artery. So the triad of the common bile duct, the portal vein, and the hepatic artery is seen as the portal triad. Okay. And this is the exclamation mark sign. So now this is the main lobar fissure of the liver. Okay, I'm sorry. This is the common bile duct. This is the portal vein. This is the hepatic artery. And that's the body of the gallbladder that's attached. So that entire thing looks very much like an exclamation mark sign. Okay, so this is just in ultrasound, this is the back to front image, but so the gallbladder, the body of the gallbladder here, that's the neck of the gallbladder, which is attached to the main lobar fissure of the liver, which separates the left lobe from the right lobe of the liver. And that's the portal triad, and you can't really make out the different constituents of the portal triad here. Okay, it looks like a big anechoic space, and the dominant part of this is the portal vein. But along here, if you zoom up, you'll be able to see the hepatic artery and the common bile duct. Okay, and that looks like the exclamation mark sign. This is a relatively fixed relationship, and you must always search for the exclamation mark sign when you want to confirm whether or not the structure that you're seeing is the gallbladder. Okay. Now, the same thing in the transverse plane. So rather than having it in a longitudinal axis, if you rotate the probe to face the 9 o'clock position, then you will be able to see what is called the Mickey Mouse sign. And here you see the same portal triad as in the horizontal axis. You have the portal vein here. Okay, you have the hepatic artery. So the portal vein forms the head of the Mickey Mouse, the face of the Mickey Mouse, and the two ears of the Mickey Mouse are formed by the hepatic artery on the left and the common bile duct on the right. And a useful rule of thumb, which is, it's just an approximate thing, is that the two ears must be approximately equal in size, and if the common bile duct is bigger than the hepatic artery, that is an indirect sign of biliary dilation. Okay. Now, what is the technique of gallbladder scanning? First is the patient position. It has to be supine in most cases, but in difficult cases, you can try the left lateral position so that gravity can be your friend, or you can ask conscious patients to hold their breath in inspiration to displace the diaphragm and gallbladder inferiorly out underneath it displaces it from underneath the rib cage to the abdomen. But it may not always help. You know, if you have the bowels full of gas, then that might actually not help. Then the orientation of the probe must be with the 12 o'clock position. Okay, the probe marker faces the 12 o'clock position and starts somewhere here. So somewhere in the mid-clavicular line, in the midline. Okay, but once you place the probe here, what you then do is you sweep the probe along the costal margin from medial to lateral, from the midline laterally, till you can see the gallbladder. And how do you see the gallbladder? You see an anechoic or a black cavity with white walls, with smooth white walls. Once you see this, you should now try to get the true longitudinal view. And for that, you rotate the probe to the left side, maybe facing about maybe 10 or 11 o'clock position. And you should try and again sweep down and get and open up the gallbladder in its long axis. Okay, and what this will do is it will give you the exclamation mark sign with the gallbladder, the main lobar fissure of the liver, and the portal triad. You should always get the exclamation mark, because otherwise there are other anechoic structures along this area, including the inferior vena cava or a loop of bowel. Okay, so always endeavor to get this exclamation mark. And then once you get it, you get other views. You get the transverse view, and you rotate the probe so that it faces something like the 9 o'clock position, and you get various different levels of transverse view along the fundus of the gallbladder, the midsection of the gallbladder, and the neck of the gallbladder. When you see some anechoic structures, they can be blood vessels or biliary structures, or it can even be other things like the loop of bowel. So always put color Doppler and identify the vessels. Also, get multiple planes. Get the transverse plane. If you have pathology, don't be fixated. Don't confine yourself just to the long axis and the short axis. You can try various oblique planes to chase the pathology as well. You can sometimes have difficult situations, and one difficult situation is that the gallbladder can't be seen at all. Okay, now obviously find out from the patient if they've had a cholecystectomy. But if there's no history of a cholecystectomy and you can't see any scars in the abdomen, then perhaps there is a problem with your scanning technique. The first thing you have to do is try positioning the patient in the left lateral position, as I said before, and ask the patient to breathe deeply and hold their breath in inspiration. Obviously, that's not going to work for you when you have an unconscious or an intubated patient. Okay, fasting the patient for just 1 hour will increase the size of the gallbladder. Okay, and often what you'll find is that the radiographers will ask you for 6 hours of fasting, and if the patient is not fasting for more than 6 hours, they will often refuse to do the scan in the first place. We can try. Sometimes it's an emergency, you don't want to do that. At least if you can't see the gallbladder, try repeating it after fasting them for an hour or so. Sometimes the rib shadow comes in the way. In such instances, try to go under the rib cage, so inferior to the costal margin. But if that's not possible because of, say, bowel gas or something like that, you can try the smaller cardiac probe. So, probes with a smaller footprint, like the microconvex cardiac probe. You can try rotating the probe so that it is in between the ribs in the intercostal space. And again, you can ask the patient to take a deep breath. Now, what are the questions that we want to answer in point of care biliary ultrasound? There are just 2 questions. One, is there cholecystitis? And second, is the biliary tract obstructed? Okay, and the questions differ from patient to patient. If a patient has sepsis, you want to know if there's cholecystitis. On the other hand, if a patient has signs of biliary elevated liver enzymes, etc., or signs of cholangitis, then you want to know whether there's biliary obstruction. What are the signs of cholecystitis on ultrasound? Firstly, you look for gallstones. Okay. Second, in the presence of gallstones, is the patient tender on the neck of the gallbladder? Okay, so you identify the neck of the gallbladder and you give a firm pressure. That's called the sonographic Murphy sign. If the patient winces and is tender, that is called the sonographic Murphy sign. Is there sonographic Murphy sign? These are the 2 hard signs. The presence of gallstones and the sonographic Murphy sign are the 2 very reliable features of cholecystitis, of calculus cholecystitis. So cholecystitis in the presence of gallstones. But there are some soft signs, and the soft signs are not as important because of both false positives as well as false negatives. And these soft signs are thickening of the anterior wall of the gallbladder and fluid around the gallbladder, so pericholecystic fluid. These are not important, but presence of these adds to the diagnosis if you already have the other 2, gallstones and sonographic Murphy sign. Okay, so to recap, the hard signs of cholecystitis, the most reliable ones are the presence of a gallstone and tenderness on pressure. Softer signs are thickening of the wall of the gallbladder and fluid around the gallbladder. Okay. Biliary obstruction is the CBD dilated, the common bile duct dilated? That is the main thing. Okay, and in some instances are the intrahepatic bile ducts dilate. So firstly, let's go to gallbladder stones or cholelithiasis. Gallbladder stones are diagnosed by a hyperechoic structure within the gallbladder cavity which produces a shadow of calcium. Okay, and sometimes you'll find that the stone is not seen but the shadow is seen. The shadow is the clue to the gallbladder stone, and if you follow the shadow you'll find the stone. Okay, now, and the important thing is you have to scan the entire length and breadth of the gallbladder in multiple planes in order to make sure that you don't miss a stone. This is an example of a gallbladder stone. Again, what you'll notice, that's the cavity of the gallbladder here, and what you notice straight away is this. There's acoustic shadow, and then if you trace the acoustic shadow all the way up, you can see the two bright white structures, hyperechoic structures. And then if you go back to that acoustic shadow, you can find that there are two separate acoustic shadows separated in the middle. Okay, so these are two stones which are both casting two individual acoustic shadows. Okay, again here you can see a lot of bright white structures, and you have lots of a band of acoustic shadowing. Okay, these are multiple stones all along the length, the long axis. Now, not all hyperechoic structures within the gallbladder cavity are stones, are gallbladder stones. Sometimes polyps and tumors may be present, and they are also bright white structures within the gallbladder cavity. So how do you differentiate a polyp from a stone, a gallbladder stone? A gallbladder stone typically moves with changes of patient position. So if you ask the patient to roll from left to right, the stone will move along with the patient by gravity. But sometimes impacted stones, so stones that are impacted in the neck of the gallbladder, will not move. Okay, a polyp or a tumor will not move at all, it's fixed. Second, a polyp or a tumor does not produce any acoustic shadowing because the polyp is tissue echogenicity, unlike stones which are typically calcium calcium, and therefore they produce a shadowing. But remember also that small stones of less than 4 millimeters in size may not produce acoustic shadowing. Also, cholesterol stones may not produce acoustic shadowing. Okay, so there are caveats to all of this, but in general, stones move and produce shadows, and polyps don't. Then, what happens if you do have a gallbladder stone, but you don't have any shadowing from it? As I've already said, small stones don't produce shadowing, but what you can do is increase the frequency of the probe, and that can often result in a greater, can increase the shadowing. And then consider the other differential diagnosis, that the polyp or the tumor that I've already said. So we've talked about the first hard and reliable sign, which is the gallbladder stone. Now we'll talk about the second hard sign, which is the Sonographic Murphy sign. How do you get it? Firstly, locate the fundus of the gallbladder, and then with the probe tip, compress the fundus, or press on the fundus, not compress, sorry, press on the fundus. Ensure obviously that you're pressing the fundus and you're not pressing the rib of the patient, because if you press anybody's rib with a hard transducer, they're going to shout. Okay, so press the fundus, make sure you're not pressing on the rib, and if you have severe tenderness, that's called a positive Sonographic Murphy sign response. And I've seen that even patients who are relatively unconscious or deeply sedated often have a wince of when you do this. Okay, so it's fairly reliable, but obviously the drawback is going to be if you have a very, very deeply sedated patient or is comatose, then it's not going to be reliable. But most patients, this is a fairly reliable and a highly specific sign of cholecystitis. Okay, let's see some pictures of cholecystitis. Okay, this is an example of that's the gallbladder, and you can see that the wall is very, very thickened with a hyperechoic structure in the neck of the gallbladder, which is producing a shadow. So that's a stone. So this is a stone in the gallbladder neck which is impacted. And from the characteristics of the gallbladder wall, I'd be happy to say that this is probably chronic cholecystitis. But obviously, you can't make that assumption, but this has the features of chronic cholecystitis. You can also see some anechoic area between around the gallbladder wall here, and that is suggestive of pericholecystic fluid or edema. Now this is an example where you have a lot of hyperechoic, ill-defined heterogeneous structures within the gallbladder cavity. Normally the gallbladder cavity must be nice and black like this, but here it's not. It's sort of, you can see this. That is called sludge. Okay, and you also have a small amount of pericholecystic fluid here. Okay, so this can also be consistent. So if you now the presence of sludge is not as specific as the presence of stones, but in the appropriate clinical setting, that is a precursor to possible cholecystitis. So you can take it as one of the hard signs. Okay. Now here you see an example of a very bright thickened wall of the gallbladder, and you have stone here. It looks as if the stone is free floating, but it's actually not. If you scan along the length and breadth of the gallbladder, you'll find that the stone does make contact with the wall somewhere. Let's talk about some of the softer signs. Thickening of the gallbladder wall. Okay. Now, first of all, how do you actually measure the gallbladder wall? Where to measure and how to measure? You measure the gallbladder wall always along the anterior wall of the gallbladder, okay? Along the anterior rather than the posterior. You don't measure it here. And the reason for that is because sometimes when you have stones along the posterior wall, it's actually impossible for you to determine where the stones end and the gallbladder wall begins, okay? So you always measure the anterior wall of the gallbladder. Second, do you measure it in the longitudinal axis or do you measure it in the round transverse short axis of the gallbladder? I don't think there's any hard and fast rule for this. I was told by a sonographer once that their practice is to have a short axis, and the reason for that is that you don't want to have an oblique view, because an oblique view can give you an artificial thickening of one wall of the gallbladder and thinning of the other wall of the gallbladder. Okay, and what you want is actually a perpendicular slice of the gallbladder, and it's very difficult for you to ensure in the longitudinal axis that you have a perpendicular slice of the gallbladder. Whereas in the short axis, you can aim for a round gallbladder, and that means that you're not cutting it obliquely. So that's my practice as well. Second, you do it from outer edge to outer edge. Okay, outer edge to outer edge. The posterior wall, as I said, there might be stones, so don't measure it. The normal thickness of the gallbladder wall is roughly about 2 millimeters, less than 2 millimeters. And anything more than 3, so 3 or more, is thickened. So automatically, what struck me was, how small is that margin of error? It is very, very easy for you to manufacture a thickening of the gallbladder, okay, where there is none. Therefore, it's a soft sign. I don't think you should put much emphasis on this unless the gallbladder wall is really, really, really thick. But even then, there are other causes for the thickened gallbladder wall. And what are these? Firstly, you can have inflammation or infection of the gallbladder. Okay, so that's the main thing. But you can have edema of the gallbladder wall, which can be because of all of these states that can produce edema. Postprandial state can sometimes shrink the gallbladder and give you the appearance of a thickened gallbladder wall. And patients with multiple myeloma and HIV, and I don't know the mechanism, can also have gallbladder wall thickening. Okay, so it's not just cholecystitis, it's all the other things as well. Right, now what is this condition? This condition is a large gallbladder. Okay, there is no acoustic shadow that I can see. There is also no hyperechoic discrete structure. I can see a lot of heterogeneous structures here, but I can't see a hyperechoic discrete structure within the wall. Okay, so clearly there is, I don't know what this means. What this is actually an ischemic gallbladder with sloughed off mucosa within the lumen. Okay, obviously it's very difficult for you to make these sort of diagnoses, but at least bear in mind that the patient is likely to be very sick, may be very tender, but because of unconsciousness may not be tender, and may have signs of cholecystitis. This could be acalculous cholecystitis. In this instance, this was actually an ischemic gallbladder. So this brings us to some of the variants of acute calculous cholecystitis. Okay, so acalculous cholecystitis. This is the presence of cholecystitis, but without any stones. So you have virtually the same ultrasound findings as calculous cholecystitis, but you will not have any stones or the acoustic shadowing of stones. So typically these patients will have a very, very large gallbladder. As I said before, it's unusual to have a gallbladder that's more than 10 by 4 centimeters. So, if you have that sort of a dimension of the gallbladder, then you have to think of, especially in a sick patient with biochemical signs of cholecystitis and a tender gallbladder, you have to think of acalculous cholecystitis. The gallbladder wall is very classically thickened, but as I've said before, it's a soft sign. You will usually have sludge. And this is from a textbook of ultrasonography. So even when you do not have stones, it's invariable, according to one textbook, to have sludge. Now, the reason a sonographic Murphy sign may be absent, and this is often because the patient is very, very sick and is either comatose or sedated. Okay, but as I've said to you before, even in such instances, if you press, often patients wince. Then you have another variant called acute emphysematous cholecystitis. Again, it's just a complication of cholecystitis due to gas-forming organisms. Now, an example of this is Clostridial infection. Okay, and the findings are exactly the same as the acalculous cholecystitis, except, and you might actually have, in addition to that, you'll have gas in the gallbladder wall, which will result in a lot of reverberation artifacts and speckling. Okay, so this is how it looked like. Can you see the bright white lines, vertical lines? If you look at it, especially from a distance, you'll have a sort of a speckled appearance. Okay. Now, there are some other sources of confusion to this whole thing. Okay, and this is a classic example of that. Okay, this is one of my first gallbladder ultrasounds, and I got the liver. Okay, and then I got this structure here, and I said, wow, this is an anechoic structure. It actually is not, but I said this is an anechoic structure. It has this hyperechoic tissue, hyperechoic lesion within it, which is casting some acoustic shadowing. Okay, and I said these are all acoustic shadows, and therefore this is in a patient who's post ERCP for stones. I said that this was gallbladder stone, except it was not. I was looking at a completely wrong structure. This is actually the loop of bowel. This shadowing is called it's called dirty shadowing. That's the duodenum. Okay, and the structure within, you can see that it's actually not white. It's the same echogenicity of the structures nearby. Second, for such a big stone, the acoustic shadow is just so discrete. Okay, whereas you would expect the acoustic shadowing from a stone to come from the entire width of the stone, and this entire area must have a shadow. So this is actually a very commonly done mistake, which is mistaking the duodenum or the loop of bowel for a gallbladder stone. Now we come to the focused ultrasound of the biliary tract, and by biliary tract, the main structure that we talk about is the common bile duct. Now, where do you actually find the common bile duct? It is always anterior to the portal vein. Therefore, in order to locate the CBD, the easiest thing to do is to locate the portal triad and search for the CBD at that place. So identify the portal vein and search there. The other location that you can find it is behind the head of the pancreas. It is more difficult to do it at that location. Okay, at the portal triad, the first thing that you do is to get the longitudinal views of the portal triad. So obviously, these are oblique views, which means that you get the exclamation mark, and the dot point of the exclamation is actually the portal triad, and the main component of the portal triad, which is the common bile duct, the hepatic artery, and the portal vein. The biggest structure in that portal triad is the portal vein, which is roughly about 50% bigger than the other two structures. If you identify the portal vein, then you search for the CBD in the form of two parallel lines. They are bright strips of parallel lines that are anterior to the portal vein. Okay, so you get the exclamation mark like this. So that's the gallbladder there, and that's the major lobar fissure, and that's the portal triad. When you zoom up to the portal triad, you have the portal vein here, and then if you can see these two parallel lines here, that the anechoic structure with these two parallel lines, that is the common bile duct. Okay. Now, normally the common bile duct must be less than half the size of the portal vein. Okay. If it becomes more than that, then it means it may be dilated. Okay. In this instance, that's the portal vein and that's the common bile duct, and you can see that the common bile duct is more than the size of the portal vein. However, apart from this subjective analysis, this is another example of a dilated portal vein. So once again, what you see is in comparison with the adjacent portal, dilated CBD. In comparison with the adjacent portal vein, the CBD here is bigger. Okay, it's about 1.5 times the size of the portal vein, and if you measure the inner edge to the inner edge, I'm sure it will be more than the normal of more than 5 millimeters, but it's probably going to be about a centimeter or so. You also have an objective definition for common bile duct dilation. The first thing is you have to measure the inner wall to the inner wall. So that's actually a measurement. Remember, for the gallbladder wall, we actually had the definition as outer wall to outer wall, outer edge to outer edge, sorry, not wall, outer edge to outer edge of the wall. Here, it's the inner edge of the anterior wall of the CBD to the inner edge of the posterior wall of the CBD. Now, there are variable definitions for what constitutes CBD dilation, but in general, a useful rule of the thumb is the starting number of your age. So if you're 60 years old, then it's 6 millimeters. If it's 70 years old, then it's 7 millimeters, and so on. The other rule of thumb is it's 1/10 of the patient's age. I like this thing, the starting number of your age. In general, less than 5 millimeters is always normal, and more than 8 millimeters is usually abnormal. But in patients with cholecystectomy, you can sometimes have a CBD of up to 1 centimeter. But in the clinical context of, if you have biochemical abnormalities and signs that are consistent with biliary obstruction, and if you have a large CBD of 1 centimeter, that's obviously dilated. Okay. And as I said, the rule of thumb thing, when you compare it with the adjacent portal vein, it must be less than half the size of the portal vein. But this is more important, this is more reliable. The objective measurements are more reliable. At the head of the pancreas, it's more difficult to identify the CBD. But what you do is you keep the probe at the epigastrium, the transducer at the epigastrium, in a transverse manner. So the probe marker facing the 9 o'clock position. And the probe, the whole transducer is perpendicular to the skin. Then what you do is you locate the confluence of the splenic vein and the portal vein. Once you do this, now sweep the probe cephalad and caudad, so head end and foot end. So sweep the probe cephalad and caudad very gradually. And now what you try and do is to locate the CBD in its cross section, and it will be round. Okay. And after that, you can rotate the probe in the longitudinal direction to get the CBD in the long axis. Okay. If you use color Doppler, you can exclude any vascular structures that are nearby. Now, intrahepatic biliary dilation. The classical sign, so first of all, intrahepatic bile ducts should not be seen at all. Okay. You'll mainly be able to see in the normal liver. You'll only be able to see the portal vein radicals and the IVC radicals. So you shouldn't be able to see the intrahepatic bile ducts at all unless they're dilated. The classic picture of the intrahepatic bile duct dilation is this: the railroad track sign. The portal vein as well as the biliary tree have thick walls, And what that does is that you have they run parallel to each other, just like here. So you'll have 3 parallel lines or 4 parallel lines adjacent to each other, and that is a classic example of a railroad track. Now contrast this with a normal liver. Now these structures here, which are anechoic, are IVC branches or radicals. They don't have any walls at all, and therefore they're smooth. You just have that anechoic space within the structure of the liver. These things here, which have the bright walls, are radicals of the portal vein. And you'll find that normally you will only see 2 parallel lines of the portal vein. On the other hand, in this particular image, you see more than 2 parallel lines, and that is because of the portal vein as well as the dilated biliary tree. So this is how intrahepatic biliary dilation will look like. What I have told you about point of care biliary ultrasound is just the surface. It's just the iceberg. The sky is the limit, and you have so many other possible applications in just even the biliary tract, the liver and the biliary tract, including cirrhosis of the liver, portal hypertension, contusions of liver, and so on. And then if you actually look at the rest of the gut, you can scan for liver lacerations, spleen lacerations. You can look at bowels. You can look for mechanical versus mechanical obstruction versus paralytic ileus, pneumoperitoneum, pancreas. The sky is the limit. Okay. Now, once you get the hang of how to scan, how to do point of care ultrasound, you can easily explore. You can study, and you can believe me, it's actually not difficult to do a great deal of abdominal ultrasound. All the best, and thank you. Lucky scanning.